Hello and welcome to Sureena Speaks, and we're on chapter 10 of the BNF, which is the Musculoskeletal and Joint Disease section. So this chapter goes over arthritis, gout, joint diseases, and a lot of the medications that's in this topic we've actually covered already, so that gives us an advantage. So when we think of musculoskeletal and joint disease, one of the main ones that should pop into your head is arthritis. So if we think about patients with arthritis, we might want to, firstly, there's a lot of treatment options available for them. So we might want to give them a simple analgesic, such as paracetamol. But if there's any inflammation associated with it, then we know that we need to give something like an NSAID instead. And for patients who are newly diagnosed with active rheumatoid arthritis, then we typically give a DMARD, a disease-modifying anti-rheumatic drug. So it's usually methotrexate plus maybe another DMARD includes cyclosporin, gold, azathioprine, sulfasalazine. So we'd give that plus a short-term corticosteroid. And ideally, you want to give it within 3 months of onset of symptoms. We can also give, for example, topical capsaicin, 0.025% cream. It's particularly beneficial in patients who have osteoarthritis in the hands or of the knee. Or we could give sodium hyaluronate, and this is given intra-articularly, and this can help reduce pain over around 1 to 6 months. The other medication includes gold, which can be given intramuscularly, and a test dose needs to be done at weekly intervals to check that it is actually benefiting the patient. Another medication that can be used in arthritis is penicillamine, and with penicillamine, patients are warned that they may not see any benefit till at least 6 to 12 weeks, and it needs to be discontinued if there's no benefit up to a year. But what happens when these medications fail? Well, actually, we can use antimalarials, and these are actually better tolerated than gold and penicillamine. So, for example, hydroxychloroquine or chloroquine, and with hydroxychloroquine in particular, a big counselling point with it is antacids shouldn't be taken 4 hours before or after taking hydroxychloroquine. It's effective in conditions such as systemic lupus erythematosus, but it shouldn't really be used for psoriatic arthritis. And rarely, a rare side effect of it is retinopathy, risk of retinopathy, so counsel your patient to get regular eye tests. And drugs affecting the immune response. So we're familiar with these medications are methotrexate, azathioprine, and as we mentioned, methotrexate would be the main one to be used in arthritis, but we could use cyclosporin or azathioprine when other DMARDs haven't been effective, but you need to keep in mind that they are more toxic. And azathioprine is actually quite effective in systemic lupus erythematosus as well. And with methotrexate, we know that if we're giving a patient methotrexate, it's a folate antagonist. So we need to give folic acid to reduce the frequency of side effects. Then we have our cytokine modulators, and these include etanercept, infliximab, adalimumab, and these can be used when other DMARDs have failed. A big counselling point with them is that they can cause blood disorders, so the patient needs to look out for any sore throat, fever, rash, infection. And one that I want to bring to light is a medication called leflunomide. It's for moderate to severe active rheumatoid arthritis, and it's given under specialist care. One of the side effects that a patient can get with it is potentially life-threatening hepatotoxicity. So patient really needs to watch out for any signs of hepatotoxicity. And in the case when a patient does get a severe side effect with leflunomide, or the prescriber decides that they should be put on a different DMARD, or even if the patient wants to get pregnant, say before conception, then with leflunomide, they will need something called a washout period, because the active metabolite likes to stick around in the body for some time. So they need this washout period to essentially just flush it all out of the system. And the ways that they can do that is either by giving the patient cholestyramine or activated charcoal. Moving on to hyperuricemia and gout. So questions in exams around gout usually test your knowledge on acute attacks versus long-term therapy. And that's where they try and sort of catch you out on. So if we started with an acute attack, usually a high dose of an NSAID is given, particularly diclofenac or naproxen. Now, if an NSAID is contraindicated, if a patient has heart failure or they're on an anticoagulant, then they'd be given colchicine instead. But it's worth noting that at high doses, it is toxic. Again, if a patient is contraindicated with an NSAID, then oral or parenteral corticosteroid might be given instead. Now, in terms of long-term therapy, there's two main medications that's given, allopurinol and uricosic drugs. Starting with allopurinol, the way that allopurinol works is it reduces the formation of uric acid. Now, in terms of gout, we can think of uric acid as the bad guys. So, allopurinol reducing the formation of these bad guys. It needs to be taken after food, and the big counseling point with allopurinol is that if a person develops a rash, then the medication needs to be withdrawn immediately. So it's really, really important counselling point, especially when a person is first put on allopurinol. With our uricosic drugs, the way that they work is they increase the excretion of uric acid. So essentially, you're peeing out all the baddies. And with uric acid, there is a risk of crystallization of urate in urine. So a big counselling point for uricosic drugs is make sure the patient drinks plenty of water. Yeah, so then they can just pee out basically. And what's really important to remember with gout, when a patient has an acute attack, long-term therapy should not be, long-term therapy should not be given at this point. So when a patient has an acute attack, don't be giving them allopurinol because actually this will make the attack a lot worse. Allopurinol and all the uricosic drugs should be initiated 1 to 2 weeks after the attack has settled down. So if we now look at neuromuscular disorders, in terms of neuromuscular disorders, you want to give drugs that enhance neuromuscular transmission. And an example of a class of drugs that can do this is acetylcholinesterases. And this is very effective in conditions such as ocular myasthenia gravis. Now, if a patient can't take acetylcholinesterases, then we might give them a corticosteroid as well. And azathioprine can be given with the corticosteroid to reduce the dose of corticosteroid that needs to be given. A bit more on acetylcholinesterases. So a risk with them though is that at excessive dosage, it can impair neuromuscular transmission. And the main side effects associated with them are muscarinic side effects, so an increase in sweating, an increase in saliva, increase in GI motility. So an example is neostigmine. It's effective for up to 4 hours, but the muscarinic side effects do put it at a disadvantage. So a patient might be given atropine instead to prevent the salivation, diarrhea, even colic. Now, another example is pyridostigmine, and it's slower and it's less powerful than, say, neostigmine, but because it has a longer duration of action, it needs its benefits in that way, and less frequent dosage is then needed. So corticosteroids can be used, for example, in myasthenia gravis, and an example is prednisolone, but be given on alternate days. In terms of multiple sclerosis, we can use acetylcholine release enhancers such as fabradine, and fabradine can help improve it can improve walking in patients with multiple sclerosis. If patients have spasticity or spasms, then we might want to use a skeletal muscle relaxant. So again, in the terms of multiple sclerosis, we can use baclofen or diazepam. Diazepam is a sedative, has sedative properties, so that's something to be aware of. And with baclofen, you want to increase the dose slowly to prevent side effects, or at least reduce side effects, avoid major side effects, and sedation. And both of these are good because they act directly on the central nervous system. And in patients with multiple sclerosis who have spasticity, that's a hard one to say, spasticity, and no other treatment has been effective, then you might resort to a cannabis extract. So in terms of nocturnal leg cramps, when a patient comes to me and they've been saying, oh, I've been getting these really bad leg cramps at night time, first question I'll ask is, are you on a statin? because typically when patients are on a statin, particularly simvastatin, they get myopathy, and as a result they complain of these leg cramps. Obviously not all patients that get leg cramps are on a statin, but you'll find a lot of them are. And the medication that's usually used for this, to help treat this, is quinine sulfate. Now, quinine is very toxic, so it should only really be used if the cramps are frequent, if they're severe, and if it's disrupting sleep, and if non-pharmacological methods haven't helped, for example, stretching. It can take up to 4 weeks to work as well, but it is a toxic one. There have been accidental fatalities with it, so when you're dispensing and giving out to patients quinine and quinine sulfate, just make sure that it isn't something that they're routinely using. Of course, if they have a management plan set up in place with their GP or whoever their practitioner is, and their practitioner is monitoring them, then fair enough. But a lot of the time, what I've seen in my experience is when a patient has a repeat prescription, they take everything. They don't really know what they're taking some of the time, and so they're taking this quinine, kind of sometimes forgetting what it's meant to be treating, and actually they've been taking it for months and months and months, when that's really dangerous. So just be aware of that whenever you're giving out quinine, that actually is the person, are they taking it every day? And if they are, maybe it's worth looking at, have they tried the non-pharmacological methods, and just reiterate to them that it is something that should only be used in very severe cases, when your cramps are frequent and when it's disrupting your sleep. It's our job at the end of the day to educate patients and make them aware of these specific counselling points, so just keep that in mind. So now we go on to NSAIDs. So benefits of NSAIDs is that they have antipyretic properties, they act as an analgesic, anti-inflammatory properties, and we know so many different examples: ketoprofen, ibuprofen, diclofenac. What's worth noting with indomethacin is that there's a high incidence of side effects, for example, headache and GI side effects. And with piroxicam, it should only be given once a day. And again, you can get GI side effects with it, and it's not suitable for children. Now we have our selective COX-2 inhibitors, for example, celecoxib, and the COX-2 inhibitors are great for rheumatoid arthritis, osteoarthritis, and they are as effective as the non-selective NSAIDs. But this sentence is quite a mouthful. But what you need to remember with the selective COX-2 inhibitors is that they have a higher instance, a higher risk of GI side effects, but a lower risk of upper GI events. So they have a more risk of, in general, GI side effects, but a less risk of upper GI side effects, GI events. It's just one of those things that you have to remember. Yeah. And what's important with the NSAIDs is that some can cause more thrombotic effect, some can cause more GI side effects. So those that can cause or have a high risk of causing thrombotic effects, we can remember as DISC, diclofenac, ibuprofen, and our selective COX-2 inhibitors. Those that cause more GI side effects or a higher risk of upper GI side effects, we can rank them from highest, intermediate, and lowest. So those that are at the highest risk are ketoprofen and piroxicam. Those that are intermediate are indomethacin, diclofenac, naproxen, and those that are lowest are ibuprofen. Now, talking about some of the medication a bit more, if we look at something like tioprophenic acid, this should not be given to patients who have a urinary tract infection. And if a patient develops any urinary symptoms, they need to report it immediately. So, for example, symptoms of cystitis, any burning or pain whilst urinating, an increased frequency of urination, blood in the urine, they need to report that straight away. It's also worth noting that Voltarol is diclofenac sodium, as opposed to diclofenac potassium. And we can get enteric-coated forms of our NSAIDs, or most of our NSAIDs, and with counselling point with the enteric-coated forms is that indigestion remedies should not be taken at the same time of day as the enteric-coated forms. And the enteric-coated forms, taking your NSAIDs with or after food or milk, can all help prevent or reduce the risk of the patient developing dyspepsia, ulceration. And we know that a big caution or a condition that's cautioned with NSAIDs is asthmatics. Some legalities: ketoprofen and ibuprofen gel, the smallest pack size, is available to sale to the public, but make sure to wash your hands before and after use of the gel. And naproxen in the form of Feminax Ultra is again available to sale to the public, but it's licensed for dysmenorrhea in females aged 15 to 50 years old. And as of January 2015, diclofenac was changed from a P to a POM because there was a small risk of serious cardiovascular side effects. We also have soft tissue and joint disorders, so for that we could give corticosteroids, and we ideally want to give it short term. If long-term corticosteroid is needed, then we need to keep in mind that corticosteroids for a long time can actually cause osteoporosis, so prophylaxis for that would need to be given. In life-threatening situations, a high dose of corticosteroid might need to be given, and then this would need to be reduced gradually and then eventually stopped. Some patients experience relapse whilst they're reducing the corticosteroid dose. So instead we can do something called pulse doses, which for example is giving IV methylprednisolone 1 gram for 3 consecutive days. And you can get modified release prednisolone, for example, for rheumatoid arthritis. Now, local corticosteroid injections have an anti-inflammatory effect, and we can give it intra-articularly to help relieve pain, increase mobility. But one side effect is inflammatory reactions, acute inflammatory reactions. So we need to check though that this is a side effect that the patient is experiencing and it's not something more severe such as sepsis. So now extravasation can occur. It's a very serious thing, and it's when you have a vein and the drug leaks out, or this is my vein by the way, when the drug leaks out or IV fluid leaks out and it causes necrosis of the area. Other causes of extravasation could be the excipients that are being used, such as alcohol, cytotoxic drugs, if a patient's on an anticoagulant, and in the very young and in the elderly. So how can we prevent extravasation? So we can give it through the central line. We can make sure that the cannula is resited at regular intervals, and we can place a GTN patch distal to the cannula because, as we know, GTN patches cause vasodilation, so this will help with opening up any vessels or small veins. And a patient should report any burning at the site of injection, and they should do so immediately. So that was preventing. But what if the person now gets it? How do we manage that extravasation? First and foremost, stop the infusion. Secondly, don't remove the cannula until you aspirate the cannula so that you remove as much of the drug as possible. You might also need to give corticosteroids if there's any inflammation, for example, hydrocortisone, dexamethasone. Might need to give an antihistamine, analgesia. And there's two main approaches to managing extravasation. There's localize and neutralize, and there's spread and dilute. If you go with the localize and neutralize route, that's good for extravasation of vesicant drugs. Administer an antidote if there is one available, and you would use a cold compress 3 to 4 times a day. If you go with the spread and dilute approach, then you need to infiltrate the area with physiological saline. It's important to elevate the area, use a warm compress, and you would administer hyaluronidase. That was close. So talking a bit more about soft tissue disorders, so we could use rubifactants, and these contain usually nicotinate or salicylate, essential oils, and these can all help. We could also use topical NSAIDs for musculoskeletal pain. So as we mentioned before, our ibuprofen, ketoprofen gel, or on prescription we can get Proxicam gel. Or we could use capsaicin, so we could use 0.025% for hand or knee arthritis, 0.075% for post-herpetic neuralgia, and the 8% patch for peripheral neuropathic pain. So that's the musculoskeletal section. So it's actually a very short chapter to go through, and what I think makes this chapter easier, as I mentioned at the beginning of this video, is that actually we've been introduced to a lot of these medicines before. And remember, just because the BNF is separated into different chapters, actually different medication appears in different places, it jumps in different places, so you can use that to your advantage. I hope you found this video useful. If you did, please give it a like, please subscribe for all the latest information, share this video, and also visit and join our Facebook page. Until next time, happy revisings.